Welcome everyone to a new episode of the Statistical Corner. Today topic is meta-analysis from the research question to the result interpretation. My name is Marco Toselli from Maria Cecilia Hospital in Cotignola, and I am happy to host this session with Francesco Bruno, our young reviewer from Torino, and our expert reviewer, Daniele Giacobbo from Catania. So the aim of today's session is to provide you some fundamental understanding of how to interpret meta-analysis. So Francesco will lead us through a presentation of a selected paper, meta-analysis, of course, analyzing the key elements. Following this, Daniele will offer his commentary on this paper, and in general will provide some insight on how to perform a meta-analysis. So, as always, if you have any question, this format is for you. So please type it in the chat. We will try to address during the session. And also another thing is very important that all these sessions are recorded, so you can rewatch at your convenient time on G's YouTube channel. And they will be available soon in the next weeks. So now let's go started with Francesco. Francesco, which is the paper that you have selected? Over to you.
So thank you very much, Marco, and thank you very much to Professor Daniele Giacobbo for the kindly acceptation of the invitation. So if we can go to the next slide, we selected this meta-analysis recently published in the European Journal of Cardiovascular Pharmacotherapy by a young team led by Professor Capodanno and Professor Valgimigli. And this paper is about the P2Y12 inhibitor monotherapy after a short adapt after acute chronic syndrome. This is the study flowchart. So the authors searched the Medline, Cochrane, and Web of Science for a randomized control trial, including patients treated with P2Y12 inhibitors after monotherapy after 1 to 3 months against standard DAPT, and they finally included 7 randomized control trial, which are represented in this table. If we can go to the next slide. So this is the studies included. So they finally included the global leaders, the Smart Choice Trial, the Twilight ACS, the TICO, the Stop DAP2 ACS, the TPAS, and the Ultimate DAPT trial, so from 2019 to 2024. And they were mostly end-stage ACS patients in this cohort. And if we want to focus on the last part of the tables, of the short DAPT was different between the trials. So it was either 1 month DAPT after 1 month dual antiplatelet therapy, followed by 11 months monotherapy with P2Y12 inhibitors, or either 3 months DAPT followed by P2Y12 inhibitor monotherapy. The drug used were either ticagrelor and clopidogrel in 2 studies. And as we can see, the standard DAPT definition in every trial was 12 months DAPT with either ticagrelor or clopidogrel. So speaking on the statistical analysis, the primary endpoint, the primary endpoint was a trial-defined MACE with slightly was different between the trials. And the secondary endpoints of interest were net adverse clinical events, all-cause death, cardiovascular death, MI, stent thrombosis, and bleeding endpoints. The risk of bias was performed with a Cochrane ROB2 tool, and the quality of study of included studies was performed with a grade approach. The publication bias was assessed with visual assessment of contour enhanced funnel plots and the Eggers regression test. So if we can go to the next one, this was a pairwise meta-analysis. As we can say, there was the two arms were standard DAPT 12 months with ticagrelor and in 2 studies with clopidogrel, versus 1 to 3 months DAPT followed by a P2Y12 inhibitor monotherapy. It was a Farrakhan twisted random effect model, and the author also performed an interaction analysis between ticagrelor and clopidogrel. And they also calculated the absolute risk reduction and the number needed to treat and number needed to arm. And interestingly, they performed also some sensitivity analysis on trials, including just East Asian patients, in trial using very short DAPT, so less than 1 month, and trial using short DAPT, 3 months in the experimental arm. So the primary endpoint, this is the forest plot of the primary endpoint. We will see in a while, in a bit, with Daniele, how to read the forest plot. But as we can see, this is a forest plot divided between ticagrelor and clopidogrel in the experimental arm. And as we can see, there was no difference in the incidence of MACE between the 2 groups, with the odd ratio, with a pooled odd ratio of 0.92 and a 95% confidence interval between 0.76 and 1.12. If we can go to the next slide, this is the forest plot of the whole endpoints, which is also the central illustration of the study. As already said, there was no difference in the pooled estimate of MACE, all-cause death, cardiovascular death, myocardial infarction, stroke, and stent thrombosis. So there was no difference in this endpoint between the 2 groups, while there was a significantly different incidence in NACE in favor of P2Y inhibitor monotherapy, and in the bleeding endpoint of any bleeding and of major bleedings. As we can see, the odd ratio are 0.75 with a confident 95 confidence interval without 1, and the same for any bleeding, so almost a 50% reduction of any bleeding and major bleeding in favor with P2Y inhibitor monotherapy. As we can see, and we will talk in a little bit, there was a high heterogeneity in the NACE endpoint and also in the any bleeding endpoint. So if we can go to the next one. So these are the interesting result of the interaction analysis. As we can see, and as already said, the authors also performed the interaction analysis between ticagrelor and clopidogrel. And we can see that there is a significant interaction with a P4 interaction less than 0.05 regarding MACE, all-cause death, and NACE endpoint, with an interaction and a reduction of the incidence with ticagrelor compared to clopidogrel in this endpoint, mainly driven by an excess of incidence of myocardial infarction in the clopidogrel group. So now it's time to ask to our expert and to focus on the statistical analysis with our expert. And so I asked Professor Giacobbo to step in and continue analysis.
So can you hear me?
Yeah.
Yes.
Thank you for this invitation. So I'm trying to summarize some pills for our friends and colleagues online. So I just want to briefly explain what is the difference between narrative review, systematic review, and the meta-analysis. So the narrative review is the common review, which is written narratively without some clear selection criteria, which are subjective. Results are not quantified. There is only a narrative and qualitative assessment of the evidence, and strengths and weakness are discussed by the authors in the paper. The systematic review is a more structured type of review, where you have some criteria for selecting the literature and searching your sources, and the methodology should be reproducible with a systematic search across databases. In this case, you generally have also a meta-analysis. It's very difficult to see a meta-analysis without a systematic review, unless it is not performed according to the PRISM recommendation. The meta-analysis is the final step. So you are going to quantify, to have values and numbers about the evidence, and you are going to present some summary estimates, taking into account with a statistical methodology, heterogeneity, and other effects that are affecting available trial and studies. If you are not going to pull randomized trials, which is the best when you are performing a meta-analysis. So there are several definitions you can find in renowned books and reviews on the topic, but yeah, I would say which is the statistical synthesis of the evidence. It's a good definition for meta-analysis. And what are the objectives of the meta-analysis? To settle controversies from apparently conflicting studies, to answer questions that cannot be addressed by individual studies, for example, when they are small, were not powered for individual endpoints or a specific setting of patients, to improve the precision, because you are accounting for generally for more populations, you are more comprehensive with a meta-analysis compared with an individual studies. And to generate new hypotheses when you are going to perform a meta-analysis to draw some conclusion for a next investigations, or to move forward with the available evidence to a new research question. And as you can see in the paper that we reviewed, the estimator was the odds ratio. What is the odds ratio? Odds ratio is you can see this is a table, the classic standard table, the 2x2 tables that include exposed and unexposed patients. The exposure is the disease. This is the treatment. So in our case, it's DAPT, short DAPT followed by P2Y12 inhibitor or standard DAPT. And the disease, in our case, the disease, the outcome of interest, so case by case. And you can see in the formula, which is the odds of a specific outcome in patients exposed, refer to the odds of an outcome in patients without this exposure. You can see we have a K, which means that we are going to repeat the process for each study included in our meta-analysis. So let's assume that we have 3 studies, A, B, C. We have an odds ratio for each study, which is transformed to be pooled in the meta-analysis. In this case, we have a logarithmic transformation, and so we will pool generally by inverse variance weighting the logs odds ratio with along with the corresponding standard error, to convert again these estimates to exponentiate these estimates in the odds ratio and 95 confidence interval. And what is the difference? We have seen only a random effects model, which is, in my opinion, the best model between random and fixed effects and random effects model. But you can see generally in meta-analysis reported a fixed effect model. The fixed effect model assumes that we have only a true effect size, and so difference are due to the sampling error. And in this case, the null hypothesis being tested is that the zero effect is 0. No, the effect is 0, is common. For with respect to random effects model, we have a distribution of true effect sizes across the studies, and we are going to have a mean of the effect size as a summary estimates, assuming that we have these values in a random samples of possible effects. So the null hypothesis is being tested is that the mean effect is 0. And you can see here we have only a true mean effect for the fixed effect model, which is I would say something ideal. It's hard to see in common practice studies that are sharing the same population, the same type of intervention, and the absence of between study heterogeneity. And the random effects model, each study have true effect size, and the summary effect is the true mean effect. What is the pragmatical implication of this difference is that the fixed effects model have a different weighting from the random effects model. So you can see that the larger studies tend to be weighted, down-weighted in the random effects model, while the smaller trials are taken more into account. And the additional component of the random effects model is tau square, which is the between study variance. And this will imply generally a larger confidence interval when tau is not 0, which accounts for the uncertainty between the two trials. So you can see that the point estimate of each trial, the odds ratio of each trial, and the 95 confidence interval is the same between the two models. What is changing is the weight of each trial, the relative weight, which is visually represented, displayed by squares of a different size. And the diamond, which is the summary estimate, is different, generally more conservative with the random effects. So as I anticipated, the two models are equivalent when you have a tau square of 0, which is a between study variance, the absence of a between study variance. The Simonian Laird random effect model is the traditional type of random effects model. Over the years, other estimators with some variation have been developed, but the concept is it's the same. This is the component that produce difference between the two models. And related to the tau square and the Q-test of heterogeneity is the I-square, which is the common statistics to describe heterogeneity in meta-analysis developed by Higgins. It's very renowned statistics, but it has some limitations. It is only one of the parameters and analysis you need to consider to explain the between study heterogeneity beyond the difference in subgroup population and treatment. Moving forward to the primary endpoint, how can we read this forest plot? So the first plot is the one of the typical plot that are included in meta-analysis, and starting from the heading of the plot, we have the key information. In our case, the number of events and the total is representative of the distribution, the absolute rate in tube population, and we have the corresponding odds ratio on the right side of the panel. And as you can see, we have also the weight of each trial, and these imply a different sides of the squares, which are the weight of each trial. So the first trial, the global leaders, involving more patients and more events, have a larger weight compared to a trial with smaller sample size and fewer events. And you also can see that we have 95 confidence interval. It is visually important that their relationship with the null line. So the null line, it's the boundary to determine the significance of an effect. You will have effects not crossing with 95% confidence interval, the null that are significant, so denoted with a p-value below 0.05. And all those lines, horizontal lines that are 95% confidence interval crossing the null line, the red line, in other words, are not significant. So for this reason, you don't have p-value in typical forest plots. You don't need it if you can compute it, and you will see that only the first p-value in this case will be significant. So the effects related to the global leaders. And this is a stratified forest plot because the authors properly grouped the trials according to the type of monotherapy, P2Y12 monotherapy employed in the study. So you will have a first set of trials using ticagrelor after short DAPT. The second group of two trial, clopidogrel. So in the first random effects model line, you have the summary estimates of the two groups, and these values summarizes respectively the first ticagrelor group and the second group, and the weight is different. So 3/4 of the available information is included in the ticagrelor group compared to the remaining weight in the clopidogrel group. And the corresponding p-value is significant for the ticagrelor group. Visually, the diamond doesn't cross the null line, and the test for subgroup effect is 0.028. Conversely, you have the diamond of the second group, the clopidogrel group, which crosses 0.95 is the lower limit of the 95% confidence interval. It crosses the null, and the p-value is 0.105. And what I highlighted is the pooled random effects. So the overall estimates between pooling both groups, and you have non-statistically significant estimates, which is displayed by the red diamond. And heterogeneity is here reported. You have I-squared, tau-square, and Q test for heterogeneity, and total heterogeneity is mild to moderate, 37%, with a p-value of 145. And finally, we have testing for subgroup differences, which is the interaction between the effects between short DAPT followed by ticagrelor versus DAPT against the effect of short DAPT followed by clopidogrel versus DAPT. So this is not an indirect comparison, as someone may say, between ticagrelor and clopidogrel, but between the effects of short DAPT followed ticagrelor versus DAPT in related to the effect of short DAPT followed by clopidogrel versus DAPT. So this is the Cochrane robot tool, risk of bias tool. It's just a qualitative assessment. It needs to be done before the statistical analysis to grade the quality of the evidence. This is the summary of the items of the domains that are assessed, like a questionnaire by the group of investigators that performs the meta-analysis. And this is the we already seen this panel. This is a nice way generally requested by journals to summarize the summary estimates and the key messages, in this case the fee for interaction. So in this case you can see visually that there is a difference between the clopidogrel and ticagrelor group. And the difference is quantified by formally by the interaction testing. And finally, we have the grade approach, which is something developed in the last, I will say, 15, 20 years, and is growing in the spread and development application of different fields of the reviews, including meta-analysis. In this case, you have like a questionnaire with a grading of the probability to have a reliable or not conclusion of your evidence according to the overall quality. So in this table, you have only the final output of the review process of the grade approach. You are going to question the validity of your conclusion in terms of risk of bias, inconsistency, indirectness, and imprecision. So in conclusion, the strengths of this meta-analysis are that only randomized clinical trials are included, which is the best when you have best scenario when you don't have access to individual patient data. So by using aggregate level data, you cannot control for between group imbalance. By definition present in observational studies. So you need only to control the differences and assess the differences between the studies. This is the methodology is good in reflecting the main standards in meta-analysis. There are multiple sensitivity analysis, which is the element that differentiate the meta-analysis, and there is an explorative interaction testing. However, as I said, we don't have individual patient data, and this is important because the authors for some trials inspected the subgroup of patients with ACS, and we have an heterogeneous time of aspirin interruption. This is wrong, I think. It's a typo. It's aspirin interruption. So we have some differences that may have influenced the result, and it would be more properly inspected by individual patient data. The analysis is time to event. So the original design would imply to use the hazard ratio, which incorporates the effect of time and dropout of patients. And two studies, as you have observed in the nice review before my part, two studies were clopidogrel monotherapy based. This is only a small part of the entire data set, so I would have more evidence before drawing conclusion, especially when the results in myocardial infarction, which is the only important, I would say, in terms of arm, the important aspect is essentially driven by the stop TAP2 ACS. So only one trial, which is an extension for the ACS component of the stop TAP2, and the original trial didn't show this effect. So I would like to see more data. And finally, there is no indirect comparison of ticagrelor versus clopidogrel. We don't have this type of conclusion by performing interaction testing. So thank you.
Thank you, Daniele, for this deep dive in the meta-analysis world, also to answer very fundamental questions and to analyzing this specific paper. So if there are not any questions from the chat, I would suggest to everyone to study this field and then rewatch this episode, because there are a lot of important messages over there. So is 8. Everyone wants a coffee now, I guess. So I would like to say again thank you to Francesco Bruno for his presentation, and also to, of course, to Daniele for these important messages. And I hope you enjoyed the session. I hope to see you again here in our clinical and statistical corner. So good day to everyone, and see you the next.